smoking cessation aid for decades with a really crazy way of giving it, like 5 times a day for a while. I mean, but people have been doing some more studies on that, and it does look like it works. And that may be a drug that it's not as selective. It's not as selective. The varenicline is probably a better drug for the purpose, but since most of the world can't afford varenicline, for countries where you can't afford varenicline, the cytosine might actually be a pretty good thing for helping people quit smoking in other parts of the world, and maybe even, I mean, I hope the Affordable Care Act solves our problems with the varenicline coverage, but if they didn't, that would be something. Okay. All right, so here is how we, so now I wanted to move to sort of how we deliver tobacco treatment in primary care so that you can see how we think about that and think about how that might relate to you. So we have what's called the 5 A's. Is that something people have heard about before? So there have been randomized trials showing, they're old ones, showing that routine advice to quit is effective, more effective than doing nothing in primary care, but that if you do brief interventions or brief counseling, it sounds like S-word, it's more effective. So, and it was turned into the 5 A's to help people remember, to help primary care doctors like myself remember this. So it was ask all patients about smoking, which is duh, we all do that. Advise all smokers to quit, which is hopefully a duh, hopefully do that. And then what was new was assess readiness to quit, and then assist smokers to quit and arrange follow-up. So it was trying to sort of keep an algorithm in our head to make it easy for us. And the problem has been that clinicians don't use the model because they say they're busy. But our model of practice is changing. That we're more talking about, Rich was talking about patient-centered medical home. That's really how primary care is going to be delivered. It's going to be delivered by a team of people rather than focusing totally on teaching the doctor to do everything. And so that's what we're trying to do, is build systems of care and embed it into routine practice flow. So practically speaking, what this is turning into is something that probably looks more like SBIRT, which is that the asking really should be done by office staff. As we have electronic health records, electronic health records have this have these standards called meaningful use. I don't know if you've heard about this, but meaningful use means that if the government has offered an incentive to physicians and health plans that if they adopt medical records, that they get extra money. And it's a reasonable chunk of change. But they can't just say, yeah, we have an electronic health record that we plug in. They have to meaningfully use it. And there are certain standards for meaningful use, and one of them is that you have to identify smoking status in the electronic health record, which is a great victory for us in the tobacco field. So nowadays, everybody will eventually, I mean, this is still coming along, but eventually it's going to be the standard of care that they're going to be asked, presumably the medical assistant or whoever checks them in, about their smoking status. So it's not something the doctor necessarily has to ask. I think the core clinician role is the advising and assessing. As I think about what I was trained to do, I was trained to take a history. More and more, the physical exam doesn't matter. More and more, it's all about history and talking with patients and counseling. And then the assisting is, it's great if you can do the whole 5 A's in the office, but if you don't have time, then linking into the health system resources or community resources. So here's the ask. These are the meaningful use questions, and these are the categories, which are really nuts, but that's what they adopted for meaningful use. So that's how we're identifying smokers. I would also point out that we should be asking about secondhand smoke exposure as well, because that's actually pretty harmful. And the question that's probably the best to ask is, does someone in your home, in your household, smoke? And then advise is, again, urging everybody to quit, and that the point is just to make it clear and positive and personalized. So stopping smoking is the best way for you to, and then fill in the blank with why they came to see you. And if you can't come up with anything better, it's stay healthy. And then you could advise your patients to have home and car smoke-free. Assessing is, we were trained to use the model, the stages of change model, where the idea was you ask people if they're ready to quit in the next 30 days, in the next year. But the Brits have come up with a different approach, which I actually like better. I can't say that they've ever been compared head to head, but it makes more sense to me. Where their perspective is, you don't ask people if that smoking is a chronic disease. You don't ask people if they want to treat a chronic disease. You simply offer them help. And so they're saying something like, quitting smoking can be hard, but there is good treatment, and I can help you. Would you like to try? And the hope is that maybe you get more yeses out of that than are you ready to quit? Because you're not really saying you have to do something on your own. This sounds more like a partnership. And then the assist. So the resources that are available nationally, as you probably know, are telephone quit lines, which I think, as you probably know, are proactive, multi-session counseling. The advantages are they're convenient. You don't have to go somewhere. They're private. They're free, and they're effective. The odds ratio was 1.4 in the most recent Cochrane review. And there's a single number, 1-800-QUIT-NOW, which then connects you to whatever state quit, whatever the state quit lines are paid for by state public health departments. So whatever state you're in, that one number then shunts you to your state quit line. And the quit lines are a little bit different. Some offer more than other resources, but they do have that. And then there are some websites that I've given you some examples of. These are not the only ones by any means. So that's something. So in many states, and I don't know if Maryland or some of these other states that you're in have this, but we in Massachusetts have a form that we call QuitWorks, which is a fax referral form. I know that fax is just so 20th century technology, but we're trying to get this new. But the idea was that there'd be this form, which you can't read there because it just doesn't reproduce, but essentially the idea was the doctor's office would fill this out, the patient would sign it to get around HIPAA issues around allowing the information to go outside of the firewall of the electronic health record, and then the quit line would proactively call the person and offer services. And because we know that if you just give them the quit line number, not very many people call, but if somebody calls you and says, your doctor suggested that I call you, and then the idea was that not only would you have a referral out, but there would be information fed back where the quit line would fax something back to you that would tell you whether or not your patient accepted services or not. So that is sort of the system that most people are working on. We're trying to make it electronic in our state as well as other states. But that's a nice system that is probably as good as we have these days. Okay, so back to our case. He selected an RT, patch and lozenge, and a month later, at a visitor call, he said he took the first quit line call, he set a quit date, he started his NRT, and he cut down to 5 cigarettes per day, but he hasn't quit. What's the next step?
Motivational interviewing to ask him what it will take to get over there.
I think I don't know if I'd call that motivational interviewing, but I would call it certainly asking him what he thinks it would take is a good idea. Getting his assessment of what it takes.
Maybe try the vericycling.
Maybe.
Maybe a lower milligram.
A what?
A lower milligram.
Why would you use less nicotine if he's still smoking?
Cut down the harm.
He's still smoking, so if anything, you might want to go up. Or you could.
I was just in the alcohol talk for a few minutes, and Betsy was suggesting a cool idea, which is the abstinence trial. Why don't you just try
Abstinence, yes.
a trial abstinence and see for a few days or see how it feels?
So that's a good idea. People are starting to talk about that in the tobacco world. John Hughes has done some of these things. It's called, what do they call it? It's kind of like, there's the Great American Smokeout where the idea is that for 24 hours you don't smoke. So yeah, they call it quit trials or something. And they're actually, his approach has been for people who aren't ready to quit, that you might try this for people who are thinking that they want to quit someday but not right now, as a way to sort of help them gain skills to say no to some cigarettes before you say no to all cigarettes. And that may be something to offer people who aren't ready to quit, because we don't have a lot to offer the people that aren't ready to quit. Everything is around, here's how to quit. So yeah, I think that's an interesting idea.
Well, of course, 5 cigarettes a day is good.
Much better
It's
than
great.
that.
You got to congratulate
Yeah,
that.
exactly.
And,
That's actually pretty good.
And what about, the other way would be a gradual further reduction.
Further
It's like
gradual
4,
reduction.
3, 2.
Yeah. Yeah, there's another thing you can try. Yeah, there's a lot of things you can do. Next step. So I said find out how much NRT is actually being used, because a lot of times people say they're not actually using much of a lozenge. So maybe he needs to be encouraged to use more. And I said bupropion interchange, but I think you all have come up with some other ideas that are really good too around other things we can do. So it's really a give and take.
But that's so important, the assessing adherence, and that's something that people in the counseling role are
We
well
forget
suited to.
Yeah, exactly. I think that would be
address.
really, yeah. And we don't do it well in primary care either, but we need to do it better, because I can't tell you how many of my hypertensives, when it turned out that the reason their blood pressure's up is that they're just not taking the medicine. Okay, so summary. I think we're actually coming to the end here. So my view is treating smoking is like chronic disease management. Use combinations, drugs and counseling, more than one drug. Use the systems available to help you. There it is. Keep trying. And the new harm reduction products are here, and they're going to be with us for a while. And I think it's more just a matter of keeping your eye on either the New York Times or the paper. The New York Times is my favorite way to get medical information. Or, it has enough interest now that it's going to get covered well as we have more stuff come on, and I think a lot's going to come on. So that's really what I was planning to talk about today. Anything else yet?
What do hospitals and other facilities use for their patients since they cannot smoke when they're inpatient?
Okay, I can tell you what we do. Our hospital, we have a smoking cessation service. We really push nicotine replacement. I think that you should be offered, every smoker who's admitted to the hospital should be offered nicotine replacement. In fact, I think that they shouldn't wait until they're in the hospital, because they're often sit in the emergency room for a long time, and once the decision has been made to admit them, they can still spend another day in the emergency room before a bed becomes available if you're in a full hospital. And so what we do is we have built into our hospital provider order entry system, which is how doctors order drugs and how nurses order things, a required question about smoking status. So we identify smoking status of all of our patients on the way into the hospital. And then what we do is, with one click, you can both identify smoker and also order a patch. So we made it simple. And then, let's see. So then, it also we were able to get our hospital to support tobacco counselors, and so we get a list from that electronic system every day of the smokers who came in yesterday. And then our counselors go and try to reach every one of them. So we don't wait for referrals because it just isn't as effective. We were able to get the hospital to agree that a standard of care for our hospital is that we offer treatment to every smoker. Now that said, we offer our counselors go in, and what they do is they first say, I'm so and so from the tobacco treatment service, and I understand that you're a smoker. I wondered how you're doing not being able to smoke here in the hospital. And then they sometimes are adjusting nicotine doses or making sure that people got nicotine that got written but didn't get delivered and that kind of stuff. So they want to make people comfortable. So they start with the soft sell. And then they say, have you thought about what you want to do when you leave the hospital, because it's an opportunity to quit. And if people are interested, they will then help them develop a plan. If they're not interested, they'll do some motivational interviewing. But there are times when the patient just says, get out of my room, and so they don't harass people. And it's turned out that these counselors are also great resources to the nurses on the floor to help them learn how to use NRT and how to talk with patients. So the nurses really like the service, like having a nutrition service or a physical therapy service. And then, so we do that, and then the question is, how do you hook them into treatment after discharge? Because that's the hard part. And so if you do counseling in the hospital without hooking people into treatment after discharge, you don't end up with long-term cessation according to the meta-analysis. So what we do is we try to get the medication that they were on in the hospital put on their discharge med list, because that elevates it to the same level of importance as the other stuff. And even though much of the time it's nicotine replacement, which of course is an over-the-counter medicine, so the docs aren't writing prescriptions, but I still think it's when the patient leaves the hospital, the nurse goes over, here's your discharge med list, and this helps to reinforce that this is part of it. And then for the counseling, what we have done is a couple of things. We have tried to use the quit line as a way of connecting people to resources. We have not found that to be entirely successful because we were using this QuitWorks form, and the QuitWorks system is built for outpatients so that they don't necessarily call you right away. And the time when you relapse after discharge is right away. So you really need a call right away. And then what happened was, it was a complete stranger. The person didn't remember what went on in the hospital. They didn't remember they said yes to this. And so it was like a complete stranger would call them and they'd say, why are you bothering me? And they'd say no. So what we've built is now we're trying in a trial that we've done one trial and we're doing the second one of a system where we're using interactive voice response or computerized phone calls. So we're randomizing people to standard care, which is just, here's the quitline number, you should use it. And the other side is you get an IVR call starting day 2. There's 5 IVR calls over 3 months. And each time it asks you if you're smoking, would you like to talk to a counselor, are you using the medicine we gave you, do you need a refill? Oh, and we're also giving them 3 months, a month of free medicine of their choice on the way out of the hospital, which is nice. Thank you all, you're paying for it through NIH, but and so we did the first trial and we showed that we were able to increase the quit rates by 70% after discharge. And the quit rates were not so impressive if you require biochemical validation, because not everybody's willing to send you their spit in the mail, but so the quit rates was basically 29 versus 15% quit at 6 months. And which is pretty good, I think. But if you do it by self-report, it was essentially almost double that, which is really a high number. And so we're now doing it in a way that the IVR, if the person says they want to talk to someone, we connect directly to a quit line, so that we're doing a warm transfer with the idea that you will not, because otherwise you lose people anytime you have an end of connection. And so that's what we're trying now, and we're doing it at our hospital and at the University of Pittsburgh and a small community hospital in the North Shore of Boston. So that's what we're doing now to see if we can, will happen. So I don't have the results of that, but I'm hoping that it will be. We also broadened our second trial to, the first trial we were more careful about enrolling people that had other substance use, because we thought that this might not be a strong enough intervention for that group of people, and we really wanted to see an effect, because otherwise we would never get funded again. I'm sorry to say that that's true. And so we saw an effect, but this time, I tore out my hairs trying to figure out, because we were always like looking at patients that were coming in going, is this person allowed or not? Because there's just so much comorbid substance use among our smokers that are admitted to the hospital that I just gave up and said, we'll take anybody who wasn't suicidal when they came in. And so now we have a much broader, more like an effectiveness trial than an efficacy trial. So we'll see if it's I don't know if it'll be as effective, but we're hoping. I really think it's more about getting people hooked into medication and keeping them on medication, and also having some support. But I think we underuse the medicines, and that I think that just some support helps. So we're trying to use that as a model.
Thank you for sharing, because that dovetails so nicely with all the talks.
Yeah.
That work is beautiful, and it dovetails
Well,
with all the
thank you.
talks this
Well, I
morning.
didn't put it in here because this was primary care, but we're trying to do the same thing with primary care. I mean, basically the idea would be to try to do the same ideas, build into primary care. We'd love to have what we call a tobacco treatment coordinator for our health system, so that you can do, we've done a pilot with this where we had what we call the one-click referral. So in the EMR, a doc could just click, forget what it said exactly, and that would generate an email to a tobacco counselor who was funded by the hospital system, who would call the patient proactively, just like the quit line would. And my thought was that that person could not only do what the quit line can offer, but also because they're within the medical record, the firewall, they could also get people on medication and communicate with the doctors if they needed to. Mostly what it turned out is that she was mostly just referring people onto the quit line. But it's still, she reached about 60% of the people, which was about what a quit line reaches, and about half of those took some kind of services. We didn't look at quit rates at all, but at least we're trying to build, kind of embed it into systems, especially as primary care is changing, so that it doesn't get lost. And I think there's a lot of opportunities to embed substance use treatment in the same way, just as we're trying to. Our hospital just recently decided to invest in substance use treatment with some of its own resources. There's been a lot of stuff. I don't know if it's here, but there's been a huge amount in our local papers about the number of overdoses, the number of deaths. The state of Vermont, the governor said this was one of his biggest priorities, was all the opioids, and so that sort of shook loose some money from the hospital to do substance use treatment, and they're going to start for our community health centers, which is where most of the problem is. The patients are located that have this problem. They're going to start having recovery coaches that are based in the health centers.
Mm-hmm.
And so my idea was, well, maybe, I just actually was on the phone with the person who's going to do it, and I said, well, are you going to require that your recovery coaches be tobacco free? And she said, oh, that's a good idea. I thought about that. So it could be that, these people can dovetail, because the skills are not necessarily all that different. Yeah.
If you didn't want to use the quit line and wanted to provide the counseling yourself, is there an evidence-based brief model for that?
Yeah, there's plenty of evidence that some kind of face-to-face works. So you can train people in this. It's not complicated.
Yes. Do you have a
Do I have a model?
manualized?
Oh, there are models. I'm trying to think where I would find them.
Can you not clear the air and
Yeah.
American Lung Society, they all have written material that could be used as a guide.
Yeah. And the websites of the CDC website has a lot of resources. Also, just looking at what's in the websites of places like that. And then I was thinking the other would be there are training programs that you can send people to. That several different places around the country do these training programs, and then once you've got somebody trained, they can train other people to do it. So I know the University of Mississippi does it, the University of Massachusetts does it, Mayo Clinic does it. There's a variety of places where you can send somebody to sort of get the training, and they'll share the information.
Are you a Marylander?
Yes.
Did you go to that table where they have all the 1-800 Quit Now information? Because they have training, and it's right over at UMBC where their headquarters are. And they actually can train you there, or they come to you. And it's a fabulous, fabulous resource. So tomorrow, hopefully they'll be there and you can talk with them.
Okay, thanks.
Yeah, you're welcome.
Could you speak to kind of the effectiveness of running a smoking cessation with an approved modality rather than face-to-face?
Most of the treatment has been in the group setting, and the reason is that I think a lot of it was that it's practical, that there was a high no-show rate when you had booked individual appointments, and also it was much more cost-effective because one person could help many people, but also from it's got the peer support, yeah. So that was the traditional. The trouble is, it's been hard to get people. We can't, even when we offer groups for almost no money, no charge at all, people just don't want to go, and I think it's that they're just busy, they perceive that they're too busy to come in, because the standard group was once a week for usually 60 to 90 minutes for 8 weeks. And then
So if you have a captive audience, for instance, in a residential.
that would be an excellent idea. Yeah, that would be a great idea. I actually think that would be perfect.
I was interested in the fax method, the fax to quit,
Yeah.
quit lines. Is that something that
anybody can access? I mean,
It's state by state, so it depends, but there is this, North American Quitline Consortium, has a website, it's NAC, it's NAQC, and it's got, you can go and find out what your quitline offers. And every quitline is different. I don't know, you probably know what Maryland offers.
Yeah, it's called Facts to Assist, and it's fabulous. So I've had patients in the hospital sign up, and I'll fax it to them, and then they are on their radar, and they get the phone calls. And I've actually had them call while they're sitting in that hospital bed, 1-800, and start right away when they're completely ready.
Yeah, there's actually a trial now that's going on. There's a series of trials that NIH funded for hospital-based interventions, and so we were one of them. But there's one that's out of Kansas that was really interesting, where they did exactly that. Where they, in the hospital, they had the counselor actually call with the patient's cell phone, call the quitline, and have the first connection in the hospital. So they already had been through their first visit, and then that. The idea was that you've made the connection, so that hopefully will last. And they should have their results out pretty in the next year. We'll probably hear about them in the next year. So that may well be very effective, and that potentially could be also cheaper, because the person who's in the hospital doesn't necessarily have to be as trained, because they're just getting people to call the quitline, not necessarily having to do all the counseling themselves. So that could be a better model than what we have. I think it remains to be seen.
What do you know anything about the insurance coverage for smoking cessation and medications locally here?
I don't. It's supposed to be covered. The brief intervention kind of thing is supposed to be.
And medication.
Well, so in most of the private insurance plans will cover prescription only medicines. Right. So they'll cover the varenicline, the Chantix, and the bupropion, and in theory the inhaler, but often that's hard to hurt the nasal spray. But the gum and the patch and the lozenge, which are the major products, are often not covered, and I don't know if that's the case here. The other question, what does Medicaid cover because in Massachusetts, our Medicaid program covers everything, all medications.
One nice thing is when they hook up with the quitline, they get 4 weeks free of nicotine patches and nicotine gum.
Oh my God.
That's an automatic knee-jerk reaction.
Do you have to do it through the fax to quit system, or
No.
can a person just call
They
up
can
and
just
get it?
call them.
That's amazing.
Yeah, sometimes what they have to do though, if they have some they're medically complicated, they give permission to the 1-800-QUIT-NOW counselor to call their primary care provider to make sure that they're able to send out the nicotine patches and the nicotine gum.
So what about people working in the substance abuse specialty program who have patients that are willing to try to quit?
Same thing.
They could get the
Yeah, I was
same.
thinking they could get the same
There
thing.
you go.
Yeah, there you go.
There you go.
Yeah.
Great resource.
Yeah, it is a great resource.
It is.
So and it sounds like Maryland is generous. Massachusetts only gives you 2 weeks. I mean, so that's great.
4 weeks. And it's a 24-hour number. It used to only be a Monday through Friday number. Now it's 24 hours a day, 7 days a week.
Oh,
Well, in New York, apparently, you can actually go online and just sign up and get patches sent to you. So, yeah. But they only give you 1 call. They don't spend a lot of time on the phone with you. So they all vary a little bit, but all of these resources are generally, we don't use them enough, and we don't hook them into our healthcare systems. And so we have opportunities to do things that we could do better with what's already out there. Which is not to say that we couldn't build better things, but at least we could do better with what's already out there.
I have a quick question for you. Those resources age limited? So if you have an adolescent who smokes, do you have to be over 18?
We do.
I bet that, yeah,
18.
Like some issue.
that's going to be a problem for me, yeah. Yeah. Well, the data we have on adolescents actually is that, because you had asked about it, was that there aren't many trials with adolescents and medication, but basically they've shown to be safe but not effective in adolescents. That was bupropion and NRT. Nobody's done a varenicline trial in adolescents. And but the U.S. Preventive Services Task Force just came out this year with a recommendation about counseling for adolescents about smoking prevention and endorsed it. So at least there's support
There's
for
some
that.
awareness there. And it just seems